question, just have me repeat. All right, so we're going to start with, this is tissue integrity issues that we're going to talk about. We're going to talk about pressure injuries. Is Lori coming tomorrow? Yeah. Okay. So there's some things that I'm just going to go over briefly with you, and tomorrow your guest speaker will go in more depth, like stages of wounds, things like that. Okay, so for today, this is just going to be pulling it from your book and a brief overview of tissue integrity issues. So first I want to start with our patient in the bed. I want you to raise your hand and tell me what potential pressure injury or tissue integrity issues do you see with this patient in the bed? Yes?
Sacrum. Skin integrity on the sacrum.
On the bottom, because?
Lack of movement, not positioning correctly, could be from diet, could be from
Okay.
medicine.
Good deal. What else? I saw some other hands. Did you all want to say what she said? That's it? Oh, come on.
The heels.
The heels. All right. What's going on there? Huh? What's going on?
Their body monitors are should not be issues.
Okay. So the heels right here, whenever they're resting on the bed, and you have all the weight there. Okay, so there are times when we have to pick that up so it doesn't touch, because the heels will break down. Okay, that's a good one. What else?
The oxygen tube.
Okay, what about the tubing? That's right, that's right. So you guys have learned how to do assessment correctly, right? So that's one thing you're gonna check is it breaking down behind the ears, or even there where it's going in the nose, because that's where all the oxygen's going in right there. Okay, good. You had one?
All of the sheets and blankets are bunched up underneath.
Yeah, what's the matter with wrinkled sheets?
It will just cause a pressure injury wherever there's wrinkles.
Okay, we didn't teach you in STNA to make a bed without wrinkles just because we wanted you to be in the Army, right? No, we didn't do that. It's because skin will break down with the wrinkling. Also, with shearing, those kind of things, when you're moving a patient in bed, you don't pull, you pick up and move because of those reasons, right? All right, what else do we see? IV, okay, there's another tube. So we have to check the site. There can be skin integrity because you've got a catheter into the skin. And it's not just the top layer of skin. We went down a little deeper, right? Because we had to find that artery or that vein. All right, what else? Anything else with my patient here?
Is there a Foley?
There is a Foley. It is hard to see, but okay, so what happens there?
Infection, possible infection.
Okay, possible infection, but what about any skin integrity?
Don't want to be laying on the Foley, the actual tubing.
Correct.
underneath you.
Yeah, right, because that will cause skin breakdown on the leg or wherever it is if it's laying on that, which is why we have to put it on an immovable part on the bed, correct? And it has to be below the bladder so it'll drain. It's gravity. All right, what else? Anything else we see here? You see anything else, Tara? Angie, you see anything else?
I do.
Okay, just tell us.
What about the head?
What about it?
It's also just resting on a pillow, not moving.
Okay, all right. So we want that pillow not necessarily down on her shoulders, but back there for support, fluff it up, right? Okay, because you can get skin breakdown on the head. I mean, think about a gentleman who doesn't have much hair, or someone who has hair loss, even a female, and that head is rubbing back there. That's a potential place for skin breakdown. All right, what do you got, Tara? Side rail on the other, what?
We have the side rail on the
Okay, there's no side rails up. Does there have to be?
Depending if your floor is.
Right, it depends on what's going on with our patient, and we can't have how many are, it's a restraint then. Okay, you can't have 4 up unless the patient says they want it up, right? Okay, that could be a potential for another area if this patient does this in the bed, and then this is resting against here. That can break down, okay, anywhere that it's touching. All right, the other is she's slouched down in the bed, okay? She's not really in the spot where it's, you know, where her bottom should be, right? Okay, good job. So when we walk in the room and we see a patient like this, what are you gonna do?
Fix it.
Fix it, all of them, okay? Pull this patient up in bed, fix that pillow, and you know, make sure the heels aren't touching. Straighten the sheets, right? Straighten the sheets. And if you see breakdown or you see a redness on the bottom, get them off the bottom. Turn them to the side. Then when you're doing your assessment, make sure that you're checking all the areas where tubes could have caused some skin breakdown, pressure areas, you know, elbows, all the bony prominences are places that people will break down. And the head and everything. So don't just walk in there with your mindset on, I gotta do this assessment, and the patient's like that. Fix it before you do anything else. No one should leave it like that, but it could be that someone was in the room, the patient's a wiggler, moving around, and then they've gotten themselves in this position. Fix it, okay? Because then you're potentially preventing skin breakdown. That's what we really want, is to prevent skin breakdown. But once we do get skin breakdown, then we have to do something about it. The skin is the largest organ of the body. I mean, we think about organs inside, but it is the largest organ that we have. It does a lot of things, and we're going to talk about all the things that the skin does. But when we do nursing process, you have to assess. If you identify anything, any pressure areas, we're going to document that and then implement. Do I need to turn my patient? Do I need to, you know, put something underneath here, pillows, or raise the heels? What do I need to do? And I implement it. I come back in an hour and reevaluate it. Is it working? Do I see less redness in the heels or on their bottom area, their coccyx area? If I don't, you know, you might want to give it a little more time. There's the potential that you can massage and move some of that we can do those kind of things. But we implement something and then evaluate it. That's our nursing process. And you can do it rather quickly when you go in the room and find a patient like this, all right? So I have some questions. And instead of everybody just shouting it out, if you know the answer, raise your hand. I do have a prize for you. So, what a blank ulcer, localized area of injury to the skin, may develop when soft tissue is compressed between the bony prominence and an external surface. What kind?
Pressure.
A pressure ulcer. Okay. This will tell me if you guys read your stuff too, right? Okay. Let's go to the next one while I get this. This is a true false. So you got a 50-50 shot, right? The first indication that a pressure ulcer may be developing is a blanching of the skin over the area under the pressure. Is that true or false? Raise your hand.
It's false.
No?
No, it is true.
It is true. Okay, that's all right.
I was thinking blanching was a little too much.
Well, and blanching means what? The skin has turned probably red,
Okay. I was
okay?
thinking it was more than that.
Okay, that's all right. So it's a pressure ulcer develops is that skin is blanched over the area. Now this is going to end up being a stage 1 because you blanch it and it'll turn back. But you'll learn more about that tomorrow, okay? So true or false again. Granulation tissue forms the foundation for scar tissue development during the proliferation phase of wound healing. Gotta know what proliferation is. Yes, Gracie. That is true. Okay. You want me to just throw this up there?
I mean,
Or you can get it at break. How about that?
that's fine.
All right, good. Okay, dead tissue that appears as dry, black, and leathery is known as what?
Necrosis.
No. I mean, dead tissue is necrosis.
Is it necrotic?
It is necrotic. That's dead tissue, but there's another name for it. Anybody pick up on that?
The eschar?
Yeah, eschar. Okay, so ESCHAR. You both can get one. That's fine, because I've got plenty. Okay, patients who are pulled rather than lifted when they're being moved up in bed or from the bed to the chair are at risk for injury from what forces? Who said that? I'll give it to you, but you gotta raise your hand. No, I'm just teasing you. All right, serosanguinous drainage, which is clear and watery, is composed primarily of the clear serous portion of the blood and from serous membranes. Is this true or false?
True.
It's true. It is not true. Anybody know why it's false? Michelle? I mean, not Michelle.
Because there's blood.
Because there's blood.
Bloody drainage also.
What is serosanguinous? Okay, it's kind of pinkish colored because it has blood and serum in it. So this is saying clear and watery. That's not the definition of serosanguinous. So that's why this is false. We'll understand that more when we talk more about it. Okay. The partial or total separation of wound layer is known as what? The result of excessive stress on wounds that are not healed. What happens if it doesn't heal? It separates. Anybody know what that word is? Angie or Tara, you want to jump in? You want a prize?
Is it dehiscence?
It's dehiscence, yes, okay? I will show you a picture of partially of that and evisceration. True or false, there's no standard frequency for how often dressings should be changed. Does that mean false? No, it's true. This is true, okay? There's no standard frequency for how often dressings should be changed. In a way, I get what you're saying, that it's false. There is usually some kind of a standard for what's going on, okay? So it depends on like what kind of dressing I put on there, which you'll learn tomorrow. There are dressings that you don't take off, so that is a standard practice. But everybody's healing is different, so that may be a little bit different, all right? But there is a standard, certain dressings that we put on certain wounds. All right, so let's get into the lecture part. This might not mean anything to you except, oh, that's a nice picture. But when we really look at this picture, what do you see? You see pots. What about them? What? What?
I say it's a texture.
Texture, okay. So you can see the one back there it's got a little rough on it, doesn't it? It's got ridges, okay, and the other ones might be a little smoother. What else do you notice?
Different colors.
Different colors.
Shapes.
Different shapes. Okay, so could we just insert people there? We're different colors. Our skin is different colors, right? We're different shapes and different sizes. Some of us have some rough spots. Okay? Some of us are a little bit more smooth. Okay, so that's the reason why I put that there, because we're different. Our skin is different. And there are people that have leathery skin, you know, tough skin if they've been in the sun, construction workers, people who do roofing. They may tend to have a very leathery, hard skin, or difficult to get through the first layer of skin. But also, Skin responds differently. Why is it that somebody with the same diagnosis, they've been in an accident, have a skin breakdown, skin is cut, and they don't heal the way somebody else does? There's a lot of factors play into healing. So our skin is different, and who we are is different. So what are the functions of the skin? Okay, so I have them labeled there for you. I have more slides than you have. That's okay, because I'm lecturing. I've put the slides for you that are important for you to know. Got it out of your book, and I just gave you what I expect you to know. All right, so these are things that you need to know. What are the functions of the skin? Okay, first of all, it protects us. The skin protects us from what? It is the first line of defense. If we break the skin, then we're starting to get into areas of vessels, organs, things inside our body. So the first layer of defense is our skin, and it protects us from a lot of things. Temperature. We perspire for a reason. Okay, it regulates our body temperature when we sweat. It comes out of our skin. Okay, so how does our skin react to that then? Does our skin break down because it's too moist? You know, organisms like to live in dark, moist places. Well, it's where the skin is. So that's the temperature. I'm getting, I need some water. Psychosocial. Psychosocial, what does that mean?
Where you live,
No, talking about the skin.
and your ability to,
Our skin will identify us. We have fingerprints. Yeah, it identifies. It also is a communicator in that sense. Our skin can tell us a lot of things of what potentially might be going wrong with our patient. So we need to pay attention to that. So psychosocially, it communicates to us potential things. What's the next one? Sensation, okay? Our skin, we feel what? Touch, we feel pain, we feel pressure. Most people do. Sometimes there is, just not that blood flow and they don't, if the tissue gets necrotic. But we have that sensation until it's lost. Vitamin D production. When we get in ultraviolet rays, it stimulates and our skin produces vitamin D. All right, that's another thing that it does. Another function is immunologic. There is an immunologic response when the skin is broken. And we're going to talk about it because right away, white blood cells are coming to that spot because it wants to heal it, okay? Things are turning from fibrin, collagen, things are happening, and that's an immunologic response. Our body automatically wants to fight it when the skin is broken. Another function is absorption. If I put a pain patch on my patient, how do they get the medication? It's absorbed through the skin, right? So we have that, our skin has that ability to help us if it's a pain patch or, any other kind of topical medication. If you get stung by a bee and you get a rash or it itches, we put cream on there to stop the itching, don't we? Because our skin will absorb that. The last one is elimination. And it kind of goes along with temperature, but we sweat. Our skin eliminates that. So we have to be careful of hydration and dehydration for our skin. All right, so let's read this little scenario here and then talk about this slide. So mine's too small, let me see. Sam, a 56-year-old man, has been admitted to the hospital for aggressive treatment of a bone infection that has not responded to usual treatment methods. Mr. Benz, or Sam, is 5 feet, 4 inches tall, and he weighs more than 300 pounds. He tells you the last time I was here, my skin got really irritated and I developed several skin wounds. So when we're talking about risk factors, and this is a scenario right straight out of your book, this is how you can use these scenarios in your book. Read them and then apply them to what we're talking about in class. What are some risk factors for Sam just from this scenario? Pressure ulcers, why? Weight. Okay, weighs more than, I mean, he's 5'4", so that means he's smaller than me. I'm about 5'6", so he's about this tall, and he weighs over 300 pounds. What? Somebody do a BMI, yeah. It's gonna be overweight, right, obese? All right, so what else? Because he is heavy, and we tend to carry it here, males, all right? What else could be happening because of that? Stomach what?
And it's like, in his extra skin, he can have like skin breakdown in his stomach, if he's got like a big waist.
Okay, because what's gonna happen when we get so big, it tends to roll, all right? And then in between there, especially females, we can get skin breakdown because of the folds. Moisture gets in there, they get hot, and the skin will break down. So he has that potential. So overweight can cause a couple things. What else is a risk factor in this scenario?
He's probably immobile
What makes you think that?
while he's getting treatment for a bone infection, so he's probably most likely.
He may have limited mobility. I mean, he's heavy, so he would be maybe difficult. Also, he's probably going to have some kind of an IV hooked up, something, so which causes more risk of falls, right? Okay, what else?
And this goes what she said, he probably can't move in the bed, and he's so big and wide that all of that's sitting against
Okay.
the side rails and, you know, whatnot. Things are creasing all the time because of the weight.
Okay, yeah,
Also, a single STNA is not gonna be able to move it by
that is
itself.
correct. Do not try to move this gentleman by yourself. Anybody. Yeah, Gracie?
Since he has a history of skin breakdown and irritation, would that also be a factor?
Could
If
be.
his skin hasn't healed all the way from the last hospital visit?
Yeah, and why is his skin is irritated and he's getting several skin wounds. Could be from an IV, could be from moisture. What? Hygiene? Yeah, that could be. He can't probably get down and do his toes, his feet. What else?
Poor circulation.
Poor circulation, because we're not moving him much. Right? And then there's pressure sitting on there. Is his age any kind of a factor? What happens when you get older to your skin?
It's more
It's thinner.
It gets thinner. Yeah, it starts getting very thin. We don't have that elasticity that we had when we were younger. It just happens. It's just part of life, right? The other is what's happening with the bone infection. Okay, so he has, I mean, it doesn't say that it's cancer, but it says he's getting aggressive treatments. So there is the potential for side effects of medication, nausea and vomiting, okay? And he's a heavy man, so he's probably sweating or potentially sweating. So if I'm losing a lot of fluid, dehydration, okay, there may be that potential. He could be running a fever with the infection, which is potentially could start to sweat, right? He could be having diarrhea as a side effect. There's a lot that could be happening, and we need to watch hydration on this particular. So he's got all of these risk factors, but there's some other ones not in this scenario that we do need to talk about as well. We talked about age. What about lifestyle? Not Sam, just all of us. Lifestyle in general. What kind of things are potential for our skin to, is a risk for our skin to break down? Nutrition, okay, definitely. If we don't drink what they say we should drink, and we, yeah, and we don't eat correctly, properly, sleep properly, all of those things play a part and become a risk. What other lifestyle things? Sedentary, yeah. We just sit around and study. I mean, come on.
Smoking, alcohol.
Smoking and alcohol, okay, good.
Exposure
Exposure to,
chemicals, I mean,
Yep.
outside, sun, wind,
Okay.
rain, whatever.
yep, sun especially. Do we all use SPF? Yeah, do we use it? Or do we cover up? Because there's, you know, potential for skin cancers, right? One we're missing here.
I feel like psychological health, like your mental health, also like that, depending on how you are isolating or what kind of lifestyle you're choosing. So that
Right.
puts an effect on.
Right. That doesn't directly impact the skin, but from what's happening with it, it could cause you to become depressed, sedentary, a lot of things which do then affect the skin. So one way or the other, yes, it could. Gracie?
Could the clothes you wear, like how tight they are?
Yeah, if they're constricting, sure. What seems to be popular these days? Yeah, piercings. You punctured the skin. Our first line of defense. Uh-huh. There's that potential, isn't there? There's that potential. Another potential is tattoos. What if you didn't get it done at a reputable, approved place? Back in the corner or someplace, you know? You got it done. Did they follow? What?
Prison tattoos.
Prison tattoos, yeah. A lot of them have them, ball players have them, but, you know, was it done properly? I'm not saying I'm against tattoos, it's just, you know, we do need to pay attention when we're assessing the skin, okay? All right, what one did we miss? What about illness? Is that a risk? Yeah, I mean, what if I have diabetes?
Okay, then your healing would be
Then my healing's probably gonna take a little longer, okay? So illnesses can be a risk factor in the sense that it's just another contributing factor to my skin.
Isn't then the use of drugs would be in cost to then you're puncturing, like if you need to have any injection and all that?
Yeah. Diabetics or addicts.
Yeah.
Mm-hmm, yeah, addicts that are putting it through with a needle. You've got all those puncture places, all right? There's a potential for skin breakdown. Some that you might not think about, like the piercings, is like if you're having a GI test, they make you what? Drink all this stuff so that you get rid of it all. What's going out with all of that?
Water.
No nutrition.
Water, but what else? Water and electrolytes. So I'm losing electrolytes, so I need to watch my patient post-op with those kind of things because, you know, it's GI, it might throw up and then I'm gonna be dehydrated again and potentially my skin, right? Okay. Therapeutics, sometimes like if you break your leg, they're gonna put you in a cast. That's gonna help the bone heal, but it's also gonna cause skin irritation. You know, the people that stick the hanger down in there to itch, because after you've been in that cast a while, it starts itching. That's not good, you can't see it, so we tell people, patients not to do that. But if I have one treatment to take care of something, there's the potential that my skin can break down because of that. Even though I need this, I need the cast, I need bed rest, okay? A mom who's pregnant and she has to be put on bed rest to save the baby, that's good. But then there's the potential that her skin might break down if she doesn't follow some things that we tell her to do. Right? Okay. All right, so wound or pressure injuries. Okay, they're categorized like this: intentional, unintentional, open and closed, and acute and chronic. So intentional would be, I need to go have my gallbladder taken out. Okay, I schedule it, I go in, it happens, right? It's planned, it was invasive, they either did it laparoscopically or opened me up, but I knew it, all right? We planned it. We planned to have this invasive, so I have to be healthy when this happens, potentially, maybe not gallbladder, but I want to be healthy, I want to be in good, maybe my weight needs to be at a certain place, so that I can have this intentional wound. Unintentional would be if they're in an accident, okay, and something in the car, you know, they hit their head and they cause the skin to open up because they hit their head on the dashboard or the steering wheel. That's unintentional. They didn't mean to do that, don't want it, but it happened. Then we have open and closed. So an open would be, you know, where you're bleeding, okay? Your skin is broken down. That could even be the accident of the head. It's the skin is open. Sometimes you can see organs inside, it's open that much, but there's bleeding, there's tissue damage, and if we have that, there is a risk of infection because my body is open to the organisms that are out in the air and around me, right? So that's open. Closed would be something like a bruise. That's ecchymosis. So the soft tissue is damaged, but my skin isn't broken. But it starts turning all these funny colors, right? So that would be a closed wound or a closed injury. And then we have acute and chronic. You know what that is? If you have something that's acute, it's probably going to heal up, okay? Even if I have an intentional or an unintentional, it's going to heal up and I'll be over it and move on with life, right? If it's chronic, that means the healing is somehow being impeded, whether it's because they have another illness or it's because they're not following a nutritional regime. So there's a reason why it's not healing, and so then it becomes a chronic problem for the patient. All right? Any questions about that? We all understand those. I tried to give you definitions up there. Yes?
So is being a diabetic would be chronic?
Yes. Yeah, because it's not going to go away, more than likely.
So if a diabetic patient gets a wound, like, you know, smashes a finger by the door or something, how long approximately it will take to heal up?
Well, there's a lot of factors with that, because are they following their diet? Are they overweight, underweight? Are they exercising? There's a lot of things that play into that. But the diabetes will be chronic. The wound may not be. We may eventually get it healed up, which is what we hope for. Oh, okay, here's a question. Raise your hand if you know it. Which type of wound is caused by a blunt instrument, causes injury to the underlying soft tissue with the overlying skin remaining intact? And somebody else. John. A laceration. No.
Confusion?
A contusion. Okay. In the question it said blunt instrument. So that would be like a rock. Okay. A weapon would have a knife, it'd be a knife, and it would cut the skin. A laceration would do that. A contusion is what? What's another name for it? I guess I should say.
Bruise?
Yeah. Yeah. Not hard. I'm not trying to trick you. Okay. All right. So make sure you read all of the question. Okay. So wound healing. There's 3 phases of wound healing: primary, secondary, and tertiary. In this picture, which one is this? Would you say?
Secondary.
Because?
Cause it's still healing.
Okay, I don't agree, but somebody else?
Primary.
I'd say primary.
Primary, why?
Because it's got the stitches in, looks like it just
Pretty
been
new.
stitched.
Okay? It doesn't matter when it happened, look at the wound. Okay? So, in the primary, a definition of that is approximated and the skin is closed, tight. And that's what's happening in this picture, right? The stitches are pulling the skin tight, but it's nice and approximated, nothing's open, and it looks good to me. It's not when it happened, it's what it looks like. Secondary is, it's not well approximated, so that's why, Susan, I wouldn't go with secondary, because the definition is it's not approximated, and that one is, okay? It's not when it happened, it's what does the wound look like, or how is it healing? Another thing for secondary might be, if you got burned, you don't get burned in a straight line, do you? I mean, it'd be very rare that you did. So the skin isn't gonna necessarily be approximated, right? It's gonna be wherever it happened in whatever form it happened, how you got burned. So that would be a secondary healing until it clears up, you know, till the skin grows back, or they graft it or something. You guys got a question?
So approximated is like in a line.
Mm-hmm.
That's what we're trying to figure out.
Yeah.
Okay, all right. Yeah, it's together. It looks good. Approximated, it's in alignment and the skin is together. There's no broken skin. Okay, and then we have tertiary. Sometimes physicians, surgeons will leave a wound open on purpose, because there might be infection in there. And what would happen if I just closed it up? It's gonna spread, isn't it, inside? So sometimes they'll leave it open to get the infection out. That's called a tertiary. That's tertiary wound healing. Sometimes they'll put a drain in there to get it out, but if there's too much, or it's continuing to, you know, make infection, you know, drainage, then they might leave that wound open. And they can clean it, we can do saline and clean it, and debride it, keep it out, okay? And then, once that's cleaned out, then they'll close it, they don't leave it open forever, but that's a tertiary wound. Okay, so do you understand primary, secondary, and tertiary? Yes?
So theoretically, a tertiary can become a primary after the infection.
Yes, yes, which is, we're always wanting it to be primary. We always want it to end primary. All right, so what are some principles of wound healing? What are we looking for as nurses, or what are we doing to create wound healing? What's the number one thing we should be doing?
Keep it clean.
Wash your hands. Wash your hands, all right? All right, what else? I heard some other stuff, I just didn't understand what you said.
Promote the nutrition.
Nutrition, okay, we can do that, especially if they're in our care. What are you eating? All right? Are they eating properly? What else are some things we're looking for when we want this wound to heal?
Clean it.
Hang on just a second.
I was gonna say clean it or change the dressing. as
Okay.
needed.
All right, change the dressing as needed. And so that might be, the doctor orders it 3 times a day, but what if it gets saturated? You know, we have to know, you'll learn, but you'll have to know what to do then too. You don't just let it bleed. I'm not supposed to change it till 5 o'clock tonight, you know, and it's noon. All right, what else did you have? Have clean skin and anything else? Or clean the dressing?
Check the surrounding skin every time.
Okay? Because we want it to be clean, we want it to be free of any kind of, anything that might potentially cause infection, right? So would this wound right here be open to the air or covered?
This will be open.
Open because,
You want the sutures to be dry out.
okay. Somebody else say covered? Why?
Open because the skin's approximated.
The skin's approximated, it's open. That's actually my wrist. It doesn't look like that anymore, thank goodness. But that was the day that they took the dressing off, and we looked at it and I got my stitches out. So the skin was approximated. Don't necessarily have to cover it up. Some will put steri strips on there just to make sure and keep it, but because I don't want anything to get in there, all right? All right, some other ones I have, it needs adequate blood supply. So if I have a wound on the bottom, I need to be turning my patient, getting them up, making them walk, get that blood circulating, because I need it to go to that area potentially. And we talked about proper nutrition and the state of health. So now we had wounds healing, but there's different phases. So like when you get a wound, this is what I'm talking about here. When you actually get a wound, what happens in our body systemically? Okay, we have hemostasis. So hemostasis is immediately when the skin is broken, immediately the blood supply is trying to go to there. Remember I said that it's gonna take white blood cells to make sure. I mean, your body automatically does that. You didn't tell it to do it, it just does it. And it's trying to provide a homeostasis state so that, you know, it doesn't get infected. Automatically that's happening. So plasma and blood will then, in this state, create the exudate. The exudate means drainage. E-X-U-D-A-T-E. That means drainage. So it's causing it, because guess what? I don't want something in there that's not supposed to be in there, so it's trying to get rid of it. And the blood supply is trying to keep it from getting infected. And if it does that and it works properly, we will eventually make a scab and the skin will grow back and probably won't even have a scar, depending on the injury and the skin breakdown. Right? Okay, so then you have inflammatory. Almost immediately, don't you, when your skin gets cut, you get inflammation, edema. And why is that? That's because of the white blood cells that have gone there, trying to keep it from getting infected, and the macrophages release in that. And in this phase, it'll last about 2 to 3 days. So immediately it's homeostasis, inflammation happens, and it's about 2 to 3 days. Now, you have to keep in mind if there's other factors with this person, their nutrition, their body, it may not be these exact days. But this is if it's working properly physiologically, in 2 to 3 days, the inflammation will probably go away, and or at least we'll probably have some redness in the area. We'll have some swelling. We'll potentially have fever, but you have a body response to that skin being broken down, and in the healing, that's what happens. Then we have proliferation. This lasts for a couple weeks or so, and during this, the new tissue starts to build. So if they had to suture that up, there's inflammation there. Can you guys see that? Okay, so the raised area, even though there's stitches, there's swelling there. So proliferation starts to take place. It takes a couple weeks, to happen because that swelling will start to go down in a couple, 3 days. And they probably will, if there's drainage, get that off of there. And then new tissue starts to form in this proliferation stage, which is then eventually when they can take the stitches out and we pull that back together again, right? Fibrogen starts to happen, collagen, but here's what happens when your skin is cut. What's underneath there? We have blood vessels, don't we? We have nerves. And when those get cut, obviously we bleed, but if we cut the nerves, okay, we cut the nerves and they go in, they clean it out, and they pull the skin back together. You don't pull those nerves back together. That doesn't happen. Now they're still there, and they'll try to find, but they don't necessarily match up where they were originally were. That doesn't happen, which is why patients will say they can't feel. There's a numbness there because that doesn't necessarily go back where it was, so you get all your feeling back and everything, okay? But this is the proliferation phase, and then we go to maturation, which is about 3 weeks later. And if you look at someone's wound, the stitches are out, there's no dressing, and you look where it was, and you guys can come and see mine if you want. There's a nice white line where the stitches were. That's maturation. Because collagen has formed, scar tissue, and it's doing the best that it can. So there's a flat, thin white line, but it, you know, everything is not fully restored. This is actually another one of my injuries. I'm really bad. My kids said wrap me in bubble wrap. But I had a bike accident and broke my collarbone. So if you look at this one, I cannot feel. I mean, I can feel that pressure, but I can't feel. And there's times when I think something's crawling on me, it isn't crawling on me, okay? I think, oh, I got some hair there, there's a spider or something. It's just a tingling, but I can't really feel that. I can feel pressure, but that's it. So new tissue formed, but the nerves did not go back where they started, okay? So everybody understand this. We're going from homeostasis to maturation when the wound heals. Hopefully, that's the best case scenario that we want, okay? There's a picture of it too, of what happens down below. So what phase would you say my wound is in?
Proliferation.
Yeah, and then how deep are we here? You're gonna get into this tomorrow though, because this is way down subcutaneous level. So I doubt the wound is that deep, right? Okay, and it's not anymore because they've sewed it up. But you're gonna learn a little bit more about those phases tomorrow. Stages, actually, not phases, but stages. All right, another question. And then do we need to, well, we're not even 11 o'clock, we're good, right? In which phase of wound healing is new tissue built to fill the wound space primary through the action of fibroblasts? Can you see it? Proliferation. Good, you listened. See, you got it. All right, so some factors that can affect wound healing. We've talked about some of them, but here they all are for you right on one page, okay? Some things that could prolong wound healing. We love for the skin to do what we just said it would do, but sometimes it doesn't because there's factors and sometimes risk factors, but factors that will affect the wound healing. So if we have pressure, how is pressure disrupting my wound healing? Because of blood flow, that's right. I'm not getting the blood flow that I should. It's getting stopped or it's slowing down because the pressure is happening, okay? All right, what's next? Desiccation is another word for dehydration, okay? So you gotta know your medical terms. Desiccation. So if our patient is dehydrated, I'm probably not gonna get the wound healing that I'd like to see, right? it could dry up, but we're talking systemically though, within the body, okay? All right, what's the next one? Maceration. So desiccation is dehydration. Maceration is, no, oh, yeah, it is fluid, I'm sorry. So it's overhydrated. We're getting too much fluid, maceration. All right, so what happens there? So my patient has fluid like incontinence, bacteria, and the skin, what's gonna happen to the skin if we lay there in the wet? It's gonna break down, right? Okay, the skin's gonna break down, and I'm gonna start to see that. So we can get maceration from incontinence, from, you know, if somebody was laying in stool, they're laying in blood, you know, they pull their IV out, they're laying there, you know, we don't clean them up just because it looks bad, we clean them up because we don't want that hydration there, because it can cause their skin to break down, right?
If you've ever left a Band-Aid on too long, you take it off and it's like, soft and wrinkly, that's
Yeah.
maceration.
Trauma. So how is trauma gonna affect our wound healing? Think abuse, that kind of trauma. So this person has bruises, okay? Are they getting adequate oxygenation to where they need it? Are they getting nutrients based on the trauma? Okay, that can affect wound healing. Now that can be a good thing too, right? Because if you've ever seen somebody who's had a wound and they start out with the purplish color, or not purplish colors, but black and blue, all right, and then it starts to change colors, doesn't it, as it heals. So we start to see some yellows and greens, possibly, or purples. We want purple because it's getting the proper nutrients that it needs, the trauma to the skin. Edema. Obviously, if you have edema, you're not getting oxygen because of the swelling. You're not getting nutrients because of the swelling. So we want the swelling to come down. When we assess people's feet or their bottom legs, and have you guys gone over like pitting edema? Okay, when you hit that and your fingers stay there for a long time till the skin rises back up. If that's that edematous, their feet aren't, whatever's below that is not getting the oxygen and the nutrients that it needs, so we need to try to do something about that, right? Wash your hands after you touch people's feet, right? Okay, infection. When you have an infection, it takes a lot of energy, your body takes a lot of energy to heal, which is why your patient can be tired and not want to move. The body is trying to heal itself, but when it's infected, it takes a lot of energy to do that. Because what we all talked about, what's happening, takes a lot of energy. So sometimes our patients need to rest so that they can have the energy to take a walk down the hall. All right, wound healing. Also, excessive bleeding. So if my wound just continues to bleed, not only do I have the potential of, infection, but I'm losing blood, right? I'm losing blood, and it could be causing clots, and that's not good because I need circulation. So if I'm getting infection, excessive bleeding, we have to watch for that. We don't want bacteria to grow. We want the infection to be gone. So excessive bleeding may cause some of those things. Necrosis, we talked about, somebody brought that up. It is dead. It's dead tissue, which is what that finger is there. That's necrotic. There's no circulation to those two fingers there. The nails are black, okay? There is eschar, E-S-C-H-A-R there, that could slough off there, that's eschar, black. So that's what that looks like. When we get to that stage, it's really hard to promote any healing to that finger, the end of that finger. So sometimes they have to cut off the dead so that it doesn't continue to grow and take the whole hand. Diabetics, a lot of times toes, they'll start with 1 or 2 toes. Eventually, if they're not getting good healing, then they just keep taking more and more till potentially they could lose their whole leg. All right, and then the last one is biofilm, where bacteria grows in clumps. So we get bacteria in clumpy forms, and that can not help in healing. And when that happens too, and you give your patient antibiotics, they're not effective. So we don't want to get to this stage because we want our antibiotics to work. So those were local factors. We have systemic factors. So circulation, systemic factors. This isn't necessarily related to wound healing, but it may prolong wound healing. So systemically, age plays a part, because like we said, just things start to break down as we get older. Our skin gets thinner. Medications are metabolized differently in the elderly population. So age does play a part, potentially, in prolonging healing. Another factor is circulation or oxygenation. They go together. Respiratory and circulatory system go together. So if our patient has diabetes, has hypertension, COPD, all of those things could prolong healing because their circulation isn't the best or their oxygenation is not the best. Also, DVTs, clots, those will all prolong wound healing. Nutrition, we've talked about that. When you have a wound, what do we need? We need protein. So we need to make sure our patients are eating proper nutrition, telling them what their diet should be. Increase your protein. Increase your calories, your vitamin A, your vitamin C. We need to tell our patients those things so that we don't have them prolong their healing. They might need fluids. They might need zinc, okay? What's the cause of the wound? So if I don't want the healing to be prolonged, will this happen again? Like if it was an accident, it was unintentional, it may or may not happen again. But if it's intentional wound where they went in and had surgery and it didn't heal very well, are they going to do this again, have surgery again? You would need to know that if they went to surgery that they had an issue back here in their history. So it could prolong healing. Will it occur again? What meds are they taking? Steroids will decrease the inflammation, but what are the side effects of steroids? So we need to know that if our patient's on those. If they're taking radiation, what will that do? So we need to know those things because it could prolong healing. Could cause some kind of a wound too. Radiation burns your skin. So it could cause a wound. All right, what's the last one? Immunosuppressant, okay? What if someone has AIDS, lupus? That's gonna maybe prolong healing because of that disease process, that immunosuppression. And treatment. Are they adhering to the treatment? Okay, diabetics don't always want to follow their diet, take their meds, injections, eat properly, exercise. They don't want to do those things, so they're not following their treatment. So if they are non-adherent, that could prolong healing, right? Did you take all the antibiotics? You know, we tell our patients, you know, take all of it. If they're not adhering to it, is it gonna reoccur again? Okay? All right, another question. Which wound complication is caused by overhydration, which is maceration, right? Related to urinary and fecal incontinence, so I answered it for you. Overhydration is maceration, so know your terms. All right, do we need a break? Yeah, take a break. Come back by